Thank you very much, Michael. It was really an excellent talk. I liked it very much. In the meantime, I tried to download some of the articles that you presented because they seem really very interesting, and so I invite everybody to do the same and possibly to go through your lecture later. I think we can start the discussion with some questions. There is at least one that came through, and I have others for all of you. So the first one that was put ahead by the attendees is to Professor Dietrich, and it is when contrast enhanced ultrasound is to be used in COVID patients.
Yeah, whenever it supports your hypothesis. If you have any doubts and if you have a pretest probability that the finding after the contrast enhanced ultrasound will give you additional information. So if we have the question of pathophysiological processes of the consolidations, I showed you very nicely that there are thrombotic areas, and you can nicely depict them within the entire subpleural consolidation. So if you are not sure, use it. In pulmonary embolism, you will find a central supplying artery to a triangular formed subpleural consolidation, and you can see perhaps in the early pulmonary embolism of this small embolic change that the entire subpleural consolidation is not enhancing. I have shown you in granulomatous subpleural consolidations like Wegener's granulomatosis, sarcoidosis. You can see enhancement of the entire subpleural consolidation. So whenever you are in doubt, you'd like to better understand the pathophysiological processes behind, then you should use it. In addition, if we have a tumor, a neoplasia, then we have to be aware that there is the early pulmonary artery vascular supply, and then we have the bronchial arterial vascular supply, and you can differentiate between a subpleural consolidation which is vascularized by pulmonary artery and by later on bronchial artery, and this can be nicely depicted. There are good studies that the timing will give you additional information. So be aware of your differential diagnosis, observe the pathophysiological processes, and apply, and then you will get amazing answers to your questions.
So there is another question that came through is how long does it take for you to do a lung ultrasound exam? So maybe Joanna, you can answer for the children, and Christoph and Michael, you can answer for the adults in case we will learn whether it is different or not. Joanna?
Thank you. Thank you. Yes, I will answer. I will start the answer as we started with our favorite answer during medical study. It depends. So younger children who are healthy or have singular changes, it's like 5 minutes. But if I examine for the first time cystic fibrosis patient, teenager, for example, after lobectomy and during exacerbation, it could be even 40 minutes. So, but mainly it's like 10, 15 minutes.
Michael?
So for me, it varies a bit, being in an emergency department, by the time pressure, how sick the patient is. A focused lung exam can be 1 to 2 minutes. Probably many are in the 5 to 10 minute range. And typically, I include a cardiac examination, including the inferior vena cava. So that's part of it. And usually I don't have more than 10 minutes to scan a patient, so it does have to be focal. I'll be honest, if the time pressure is not significant, the examination gets longer the more interesting it is. So the more findings I have, I'm always recording, changing image magnification, maybe adding on color Doppler, maybe switching probes, and then it gets much longer. But for me, I typically have about 5 to 10 minutes at most for an exam.
Christoph, in a unit of internal medicine, if you are using lung ultrasound rather than
it's pretty much the same as Michael explained. It's 1 or 2 minutes if I'm looking for multiplicity, multilocular subpleural consolidations, posterobasal in a sitting patient, and it's a very short examination. I cannot exclude anything by lung ultrasound. So I'm not looking for a solitary subpleural consolidation wherever I can see it. I'm looking for multilocular, many of them. I see the B-line artifacts. They filter me that I should look carefully to the pleural line, as nicely shown by Michael. Then I focus with a high frequency transducer. So it's in between to have an idea, 1 to 2 minutes. And if I go into detail, educate and whatever, 5 to 10 minutes, pretty much the same.
Okay, thank you very much. If there are no other questions coming from the attendees, I will put some questions. One is we have seen how nicely ultrasound can depict images and illustrate pathophysiology. Going to the clinical practice, where do you see the best application or the best application, singular or multiple, whether at home, so for a territorial assessment of patient, to filtering them before they come to the hospital? I'm speaking about now the COVID pandemic situation. Or at the emergency department to screen if it helps for patients to be admitted rather than to be sent home, or during the course of the admission. So they received whatever imaging at the emergency department, they were admitted to units, internal medicine or whatever. Is there any subsequent use to monitor the course of the disease? Does it help? Not just we see nice images. What do you think should be the patients who should, if any, receive the scan? So I would like to have these 3 points of view, whether in priority, whether you think it is the best use is at home by a physician going to visit the patient at home, at the emergency department, or when the patient has been admitted at the different levels of admission. I know that there is no rule, so your personal point of view. Joanna, ladies first.
So, thank you. So I think it has applicability everywhere. I mean, it depends what you dispose of. Yes, I would be happy to have my own personal ultrasound connected with my iPhone, because it would help me, to diagnose neighbors' children, for example.
I'm not recommending in your hands that are full experts. If we have to give an ultrasound scanners to the average physician.
Yes, I believe that after relatively short training, we are able to equip general physicians, pediatricians, internal medicine specialists with basic knowledge of the ultrasound findings, which could help them to differentiate and to take, for example, the decisions on hospital admission. Exactly, the bronchiolitis and differentiating between bronchiolitis, pneumonia in younger children would be especially of great help.
So if you have one scanner and 3 doctors, one working at home, one in the emergency department, and one working in the hospital, to whom will you give your ultrasound scanner?
Oh my goodness! Why such short supplies?
Just to have your, you said everything, so obviously it is useful everywhere, but
I work in a hospital and I use ultrasound during duties to make a quick differential diagnosis when I have a patient with dyspnea. Oh, sorry.
Sometimes we have to make choices. So where do you think it is really the best place for ultrasound over there? Okay, now it's fine. Okay.
Now, is it fine? Can you hear me? Hello?
So we missed your answer.
Yes, because I work
yes.
in a hospital, I cannot get rid of ultrasound, so I would choose hospital.
So in hospital. Michael or Christoph, who would like to take first the answer?
I'm
Michael.
happy to try.
Michael?
So I think it would be tremendously useful, and especially for following patients, because clearly there's a body of literature establishing that changes in severity correlate with clinical deterioration. But something that's often overlooked is that these are patients that can deteriorate for other reasons. And if you have lung ultrasound findings that have not changed, let's say they're moderate in an admitted patient, but yet oxygen requirements are going up, saturation is going down, remember that these are patients that are at much greater risk for thromboembolic events, and that may push the clinician to consider pulmonary embolism. So there are, I think, many reasons to continue using lung ultrasound throughout a patient's stay to manage them.
So just to follow up on this issue, you said that this could be useful to monitor the situation over hours of days. How do you quantify? Because to say something has changed, you have to say this is worse. And if you are the only one performing ultrasound, you can have in your mind, in your memory, the situation of the day before. Otherwise, do you have any numerical score that you utilize in your unit to say that this is worsened? How can you assess that the situation is stable rather than it is changed, in case that there is not only one single physician performing ultrasound?
So using one of the lung ultrasound scores, I'm personally a fan of using about 12 zones total for the lung exam, so 6, 3 front, 3 back. And I think even if you're the only person doing it, it's a bad idea to try to keep in your mind, because if you're busy enough, like during times of COVID, you can forget. Was this patient, did they have lesions here before or just lower? So it has to be something that's consistent, reproducible, and a score, unless you want to draw every time on a patient's chart where lesions were and what they looked like. Ideally, it would be automated or some sort of a score that's available in the medical record, because even for one person, if they're busy enough, that'll soon fail, and then especially over days. So I think pick a lung score system that you like, that fits with the exam you prefer to do, and utilize that and document well.
Yes, just Christoph. So you agree? If you have only one scanner, would you use it in hospital or at home or at the emergency unit?
So first, what is your guess? Then I give the answer.
No, I have no guess. I listen to you.
Okay. Since I'm at the end of the food chain, and as a pneumologist, I'm interested in characterization of how to say a problem. Certainly a very good high-end machine in the hospital is my personal preference, but it's my personal preference. It's not a general, how to say, advice.
Okay. And just to reinforce what Michael said, that the score might be useful. I'm not sure whether it works, but I know that it happens that patients are admitted from the emergency department because of some ultrasound findings. This might help to decide whether a patient is better sent home or admitted. But if there is no score, when they come to us, we repeat the ultrasound, and in a way it is not comparable, because if there is no numeric report, it's difficult to say if there were consolidation, they have increased much or not, if they were in the same location. So I would recommend a score. Michael, you said that you prefer the 12 zone score, and this is also what we usually adopt. Have you any preferred score for COVID patients or for lung ultrasound in general? And also, Christoph and Joanna, if you are using a score, which one are you using, if any? Michael?
Yeah, I think hopefully I caught your question correctly. I do prefer the 12 zone score. basically up to 3 in the zones. That's worked well for me. Just to add on to what you're saying, I think there has to be continuity of documentation between the emergency department and the wards or the ICU, so that there's no confusion between what was seen in the emergency department. And this is where having some sort of system to be able to document images ideally is helpful, but at least the score. And hopefully I answered your question, at least in part.
Yes, if you can give us more details about the scoring system. You said up to 3, so 0 is completely normal. 1 is when you start seeing more than 3 B lines, or how do you assess the score? 0,
Right.
1, 2, 3 in each zone, I guess.
Yeah, and as you mentioned, it increases with abnormal findings, with 3 being disrupted pleura with coalesced B lines or reverberation artifacts, and the 2 being multiple reverberation artifacts. Once you have the coalescence and widening, that gets you the highest score. And then obviously the more lung zones you have, with 3, the more significant the abnormality. And I think there are many versions or subtle differences of these scores, and I just think one needs to use them consistently in their medical center.
Yeah, because I think this is one of the major problems, that there have been so many different proposals, and these, even within the same hospitals, different units might use different scores. For instance, if small consolidations contribute to a score, or they should be reported separately. If what is the larger consolidation, which is the size threshold by which we state a small one or a bigger one, and if consolidation should be kept separated from the increasing number of B lines. And I think this created a bit of confusion. This is a bit normal, as there is no validation, but actually it makes it difficult to compare the evolution of a patient if this patient is assessed in different wards.
Yeah, in my facility, there's no consistency. The wards, the ICU, and we use different scoring systems. There's poor documentation of them, so it frequently causes confusion, which actually usually leads to increased radiation exposure for the patient, more X-rays, more CTs.
Yes. Christoph, do you want to comment on the scores, or you use them, or you don't?
As you might have seen or not seen my presentation, there is yes, no. I can't count above 3, and there are no scores. So I see a consolidation, I see pleural irregularity, I see B lines, and if it fits together, it's very indicative in a pretest probability setting of COVID. And I don't care too much about probabilities below, and I can't exclude. Also, for pleural effusion, I'm interested if there is no pleural effusion, because it has a meaning. If there is little pleural effusion, I have a diagnostic problem to solve why there is pleural effusion. And if I have a large amount of pleural effusion, I treat. And therefore, I'm interested in distinctive answers, and scores do not play a big role in my life.
Joanna, in children, do you have also the 12 zones, or the chest of the children is too small and they are reduced to a lower number? How is the situation?
You know, in children, you can have it 1 hour, a patient weighing 3 kilograms and a patient weighing 120 kilograms. So it's quite a big differences. But we do not use scores on everyday practice, I must admit. So we use more descriptive elements. So we also use those 12 zones, as Michael said, but we describe what we see, and we use anatomical descriptives to be able to compare. So I am pediatrician, pediatric pulmonologist, and I do work together with pediatric radiologist who is also performing lung ultrasounds. And we work together for scientific purposes on CF children, and for those purposes we made an inter-observer study. So for this study we also assessed children in scores, but it was just for scientific purposes. If we want to assess them normally in everyday practice, we just use descriptives. It's easier. I mean, then you know, for example, so we took smaller consolidations up to 1 centimeter, and then we just write if they are numerous or singular and in which zone. If we have larger consolidations, larger meaning above 1 centimeter, the biggest dimension, then we also describe at least 2 dimensions, if possible 3 dimensions, so that then we can compare.
Okay. There are no other questions coming from the attendees, so I put another one. This is a let's say, organizational question. When we perform lung ultrasound, usually we think this is sort of extension of the physical examination. So it is performed by the physician in care. Is there any value of asking an ultrasound expert, a radiologist, a lung ultrasound? Like when we ask for a request for an abdominal ultrasound. For an abdominal ultrasound, we don't, not all wards perform them in-house, but they ask to the radiologist to perform it, or for deep vein examination. Is the same true for lung ultrasound, or lung ultrasound is valid only when performed by the physician in charge as an extension of the physical examination? What is your opinion? Do we need to set up services of ultrasound which perform also lung ultrasound for other units, or this is not valid in this setting? Christoph, maybe you are the most experienced here. Do you have an opinion on this, or who else would like to?
Yeah, so at the point of care, the clinician should do the examination with a certain question to be answered and a symptom, dyspnea, to be solved. And whenever we have a specific peripherally located tumor or a lesion to be biopsied, it's a very special pneumological or oncological question. It might be in a certain and different setting. So I would very much differentiate between the point of care a clinician should answer and should give the information into his decision making. And the more specific the question to a certain otherwise diagnosed pulmonary nodule or whatever, then it could be performed within a very specialized setting using contrast, ultrasound, elastographic measurements, biopsy taken, and whatever. So it's a little bit of the entire range.
Okay, thank you. I think this is, I don't know if the other colleagues, Michael or Joanna, have the same opinion, or they want to tell something before moving to the next question.
Go ahead, John.
Sorry. In my experience, I do not perform ultrasound of any other parts of the body. So when I need the differentiation, for example, ultrasound of the mediastinum, or have doubts about the upper parts of the abdominal cavity, I ask the radiologist, and we perform the examination together, so that we, you make a consultation in real life to focus on the patient and to collect the knowledge from clinic and the knowledge from radiology.
But you perform examinations only for your patients, or other pediatricians ask you to perform ultrasound for their patients?
Yes, I perform both. I mean, I perform also for other pediatricians, because in my team, I'm the only one performing ultrasound. So.
Okay. Michael, you want to say something?
Sure. I've been doing point of care ultrasound, I guess, for about 28 years now. And I'll do ocular, cardiac, musculoskeletal. I do nerve blocks, lungs, done pretty much almost everything. And I've watched people use ultrasound, adopt it, entire specialties, have taught people. And my belief is no one will do better with ultrasound than the treating physician when they're scanning the patient. So the surgeon that takes out gallbladders will have a better sense for what really constitutes cholecystitis than anybody else. When you have consultative ultrasound, although it may be necessary in many cases, it adds in hours to days in delay and removes that process from the patient's bedside. So as long as skills are adequate, that clinician, that physician will always do the best job. So if I could not do an adequate ultrasound for Joanna that compares to what she can do on her patient, or for Christoph. So I think it's up to the physicians themselves. Obviously, if the physician cannot adopt ultrasound, cannot gain a required expertise, then someone else will have to do that for them. But specifically for specialists, I think they can have an understanding of a disease process or an area of anatomy more so than anyone else, and they can reach a state of expertise or even artistry beyond anybody else. That's just my opinion.
Okay. I have one last question, moving to the education topic. We different ultrasound societies have already listed the number of examination and the time to learn when you attend the practical courses attending ultrasound centers. And this is quite easy because ultrasound office perform all examination and receive patients coming from other wards. How long will it take when you've already attended the theoretical courses to learn practically to perform lung ultrasound? Usually, how long do you recommend the physicians to stay with you, and what is the best setting to learn? To stay in intensive care at the emergency department, or to do the rounds in internal medicine units, testing patients with cardiac failure? Or what are your point of view about the needed training to become I don't say skilled, but at least sufficient in lung ultrasound? How long does it take? Michael, you want to answer? You have an experience in education in ultrasound, sure, but it's also a very huge experience. And
these are tough studies to run. You know, some of the best learning curves we have out there show at about 25 to 50 examinations, adequate competency starts to show, not necessarily expertise. At the same time, you have real authorities in lung ultrasound that say it's so simple you hardly need to learn it. My experience is if you had to pick one setting where to learn a lung ultrasound, it would have to be the emergency department. And not because I work there, but because you need to catch different points of various lung diseases. If you're only in the ICU, you'll only catch fairly sick people. If you're only in a clinic where no one sick is allowed, you'll catch more chronic issues or normals. So ideally, you would study in all of those locations to get the best experience: the wards, the ICU, clinics, chronic patients, acute patients. But the one place you can catch all of those over time is the emergency department, because I'll have patients that are chronic, that have deteriorated and are coming in arrest, and I have to intubate them. That correlates to certain findings. I have patients that are mild and go home. That correlates to certain findings, and in between. I do think ultrasound of the lungs is depicted as deceptively simple. Well, actually, it's depicted as simple, and that's deceptive. I think there's so much to ultrasound that people learn over time, paying attention to the pleura, subpleural consolidation, overlap of findings between different disease processes. And I personally think that'll take probably 50 abnormal examinations or more, because the normal lung examination as opposed to the normal gallbladder examination or the normal examination of the ovaries with endovaginal ultrasound, where anatomy is always different and you learn from every exam. The normal lung ultrasound exam is less exciting, less interesting, less varied, and you really depend on the abnormal ones. So I think probably at about 50 abnormal lung ultrasounds, I would start to feel comfortable, but it also depends on what the person is looking for. If they are a trauma surgeon and they only look for pneumothorax, then probably they need much less than 50.
Thank you. Christoph, you would like to add anything or?
Very nice explanation. So there are different concepts. One concept is a lifelong learning experience, because pathological findings are sometimes rare, and different locations have been mentioned. So it's lifelong learning. And if you have a certain symptom, dyspnea, in the emergency room, you can educate a monkey to do it very fast and very easy and precise. And sorry, apologies. And it depends on your perspective. So the normal lung ultrasound can be learned pretty easy, and the pathological findings, it's very long, lifelong experience.
Yes, always intriguing, always something new. There is no day in which you cannot learn anything. I totally agree, Christoph. Jan, do you want to conclude with nice words from lady, as we have to close then? It is after 3.
Yeah, I agree, of course, with gentlemen. Maybe apart with this monkey part, but okay, the technically it is true. But as I always said to my students, the processor, which is important with in clinic and in lung ultrasound, is not the equipment. I mean, not the lung ultrasonograph, but what is inside here. So the learning curve, how steam it is, depends not only on the technical skills, but what you have of medical knowledge in here. So.
Okay, thank you very much. It is already half past 3, and I would like again to thank the organizers for inviting me, but I do sincerely apologize for being late, but these are really very crazy days. It has not been as bad as now since the last 12 months, and let's see what happens. I thank all the speakers for their lectures, but also for the nice discussion. They provided very experienced and heartily explanation for what they reported. And I thank all the attendees for staying until now, and I wish everybody really a recovery from this bad situation, and I hope that in the meantime what they've learned today could have been of some help to improve the current management of our patients. Therefore, I greet all of you and say goodbye and see you next time.
Thank you very much.
Ciao.
Thank you. Grazie, Fabio.
Thanks to you, Christoph. Sorry again, I could not be in time.